We have a little break for some questions. We have some questions from the audience. The first, Dr. Wilson, there's several questions about the SilSoft lens. A couple of people asked about how you get payment for those. Does the hospital eat the cost? You pass it on to the patient? How does the payment work for those?
Well, the way we have it set up, the hospital is including that as part of their facility costs. So they are, I'm not using some of my patch and shield, and I'm considering it, it part of the postoperative care. So they're purchasing these, one per infant instead of an intraocular lens or other parts of the package. Because I only stock one base curve and I only ask them to replace each lens as I use it, they consider it like pulling a shield or something out of the Pyxis. That's the way they're looking at it. And you have to sell it that way, is that you're substituting one piece of equipment for other things that might be part of their surgical package.
What refractive error do you shoot for?
We're usually aiming for -1 to -2. The biometry will give me the power of the contact lens for emmetropia, and then I just pick the next power in the SilSoft. They only come in 3 diopter steps. So if it says that power for emmetropia is 31, I put on a 32. I just put on the closest one, given a little myopic start.
And do you check intraocular pressure first post-operative day? There's concern about that contact lens affecting that.
Yeah, with the contact lens in place, I mean, we looked at our intraocular lens patients, and the first post-operative day pressure is not near as important as it is later. Later, when the steroids are still on and I take the contact lens out, then I put the pressure in. If I'm worried about the child, I'll take the contact lens out and check the pressure. Or I'll slide the contact lens to the side and check the pressure. Ideally, with the contact lens in place on the first day, you want to talk to the parents about putting the drops in and just go with that if it looks clear. So it's and I'm not using a viscoelastic, so it's very rare that first postoperative day pressure is going to be important.
Some people inject subconjunctival dexamethasone. And you may or may not do that, but is the contact lens going to interfere with that?
Yeah, that's a good question, because we've done a few clinical trials years ago, and I remember Dave Plager and I having this conversation. We were really worried that the protocol on some of these clinical trials wouldn't let us do subconjunctival injections, and so we had to stop because we were doing, say, a Durezol trial compared to Pred Forte. I never missed it. I never missed it. So I haven't used a subconj injection of steroid in years. I mean, in more than a decade, and I haven't missed it.
Thank you. This is for all the panelists. Do you sit temporally when you do your cataract surgery, and if not, why not?
I sit at the head of the table. I'm more comfortable that way. I don't sit temporal. I think when kids rub their eyes, I like to have my wounds, even if they're at 10 and 2. With the Bell's phenomenon, they're under the brow. Since kids don't have big overhanging brows, I like superior wounds rather than temporal seating. So,
yeah, I also like the superior wound. Main reason is that at least the lid covers, and if the child is rubbing, temporarily if the wound is there, they can just put their finger directly on that. So I do the same.
So I'm glad I'm on the panel because I do temporal wounds. So I do temporal wounds if I'm putting an implant in, and I sit at the top of the head if I'm not putting an implant in. And my reasoning is very simple. There are 3 things that I think in the younger the child, the greater the effect is of these 3 things. Number 1, I never use a traction suture. Every child that I operate on for cataract surgery has to be paralyzed. And every child has to have isoflurane and not sevoflurane. And the reason for that is that if you go back in the literature, and back in 1967, Noel Rice and Moorfields showed that when you put a traction suture in a child in the superior rectus under the age of 3, you distort the vitreous base. And so in order that I'm not having a distorted vitreous base, that's why I like them paralyzed. And that's also why I like to sit temporally, because my access is unhindered. I agree, the child's brow is normally not that big, but you're still having to go over the brow. As far as rubbing the eye is concerned, you know, I'm suturing with 3 to 4 tenovical sutures, and you know, and they have a shield on for the first week, a pad on for the first 24 hours. So I have not found that ever to be a problem, but for the reasons I've stated, I think distorting the elastic sclera is a problem for me. I don't feel comfortable doing it.
Can I ask you another question, Dr. Nischel? Do you, at what age do you perform primary posterior capsulotomy, and is there any preoperative test that can sort of help you predict who can do a YAG and who can't?
So I'm glad you've asked that, in the sense that that's changed for me. I do 4 and under, I do a primary posterior capsulorhexis with anterior vitrectomy. From 4 until the age of 16, I do a primary posterior capsulorhexis. And I do that because I don't care what anybody says, there is no age where a YAG capsulotomy is easy in children. And that case I showed you had so many pitted points on that lens. It was crazy. And I think that's why I prefer just to do an opening. I don't know what my colleagues do.
Yeah, I do capsulotomy and vitrectomy till 8 years. And beyond that, 8 to 15 years, I just do capsulotomy.
Yeah, and I agree. You should learn to do a primary manual posterior capsulorhexis without a vitrectomy. I don't think doing the vitrectomy adds very much risk. I understand that if you can avoid it, avoid it. But I do agree with the panelists that I get a lot of failed YAG lasers sent to me where the YAG laser opened the capsule, but there are bits of capsule in the form vitreous, is all these floaters and all this material that won't get out of the way, and then I have to do a pars plana cleanup. So if I can avoid the YAG laser, I will, even though some YAG lasers go great and they're just like an adult. But I have a bias to take more posterior capsules as I get older rather than fewer.
One question is, what is the minimal white-to-white distance you would consider an IOL, either primary or secondary?
Can I just say, I don't look at white-to-white anymore. How many of you have linear ultrasound? How many people know what a linear ultrasound is? Okay, so the linear ultrasound, in your OR, if you ask anesthesia to let you borrow the hockey stick ultrasound probe, it's what they use to find veins when they can't find access. All of those, GE, Accutome, Acuson, that probe is safe to use on the eye. And when you put it on the eye, you can measure the capsular bag diameter. You can measure equator to equator of the lens and add 1 millimeter. In fact, I think it was Dave Apple, I'm not sure if you're on the paper, when Dave Apple did his work on the capsular bag diameter.
Yeah, I was. Yeah.
So he showed really nicely that you add 1 millimeter, and if your capsular bag diameter is greater than 8 millimeters, you can put an implant in safely. So I have patients who come in with a corneal diameter of 9 or 10 millimeters. 9 millimeters is the one that you normally worry about, but the capsular bag diameter is actually 10 millimeters. And I know that I can safely get an implant in. So I rely on the capsular bag diameter, but you need the linear ultrasound in order to do that.
You can assume that the capsular bag is slightly greater than the corneal diameter. Corneal diameter of 9 is minimum for me, which would give me a capsular bag of 10, and the lens is usually 12. We don't have any downsized intraocular lenses. Now, it doesn't mean that every child that crosses the 9 millimeters I'm going to implant, but I probably wouldn't consider it below 9 millimeters.
Dr. Ramesh, do you have data on the eventual vision of the infants that you've implanted with IOLs?
Yes, we are looking at the 10-year data now. So the results we are analyzing. Close to 60% of them have got vision better than 20/40 in bilateral, not in unilateral. Unilateral, the best what we got was 20/80 in 30% of the patients. And at this point of time, I don't have the the subgroup analysis, but most of the patients have it. And whoever does not have good vision is because of the poor follow-up.
Okay, thank you, Ramesh.